Jessica Kahn. She is an infectious disease physician and worked in the TDCJ for several years, and then decided to go on vacation for a while in Seattle. Apparently Seattle has wonderful, wonderful summers, but the winters aren't so hot. And so after a little bit of that, decided to move back down here and take up her old job again. And so we're actually very happy to have her back with us. And I think most of you know her, and if you don't, you should get to know her. And she's going to tell us about basically treating HIV in the TDCJ and some of the challenges and that poses. So without any further ado, Jessica.
Thank you. I'm sorry. Google's to blame. Apparently, Google didn't know where Levin Hall is. Okay. My slides are up. Oh, there it is. Okay. As Dr. Kaiser has said, we're going to look at the challenges involved in corrections care, or what we face when we treat our HIV patients in corrections. There. Okay. In all fairness, I have participated in the advisory committee for Gilead, which is actually the maker of a number of HIV medications. But we will not be discussing any HIV medications in this lecture. Okay, objectives. We want to know what are the challenges. We want to know what's the differences as far as treating HIV patients in the free world and in corrections. And we would like to find innovative ways to overcome the challenges. As far as demographics, the prison system, whether it's the jail system or the prison, has got the lion's share of HIV patients, not just in the U.S., but in all over the world. Okay. So our problem is not unique. For the U.S., we have 1.57 million that are incarcerated right now, and about 150 are in Texas facilities. So that's about, we share a good 1% of the total people incarcerated in America. And of that, we have about 1% of HIV, of inmates that are living with HIV. Excuse me. And that's about the national average. That's about 3 times what we now know as far as what's available or the people living with HIV in the free world. So we got the burden of HIV in prison is a lot bigger than what you have available in the free world. Now, our first challenge, as I mentioned, 113 units. And that does not include the jails. That does not include the privately operated prisons. So we like our prisons in Texas. And it's spread over a big portion of the state, as you can see on this map. Our problem is not unique. A lot of other states, a lot of other countries have similar problems as far as how do you provide quality HIV care in such a huge geographical area. Are you going to put HIV practitioners in each of the prison system, or you will have HIV doctors traveling from unit to unit in order to do their care? Now, with the advent of technology, Texas is actually one of the pioneers of telemedicine, where you become the star of your own show. You're on camera, the patient on the other end is also on camera, and you guys talk to each other. Now, what made this possible is the advent of the 2 things that allowed us to be able to do this. One is electronic medical records, in which the doctors from 1,000 miles away are able to look at the records of the patient, and The other thing is the employment of infection control nurses in the unit. So we have, so to speak, boots on the ground that become our surrogates in order to check on the patients that we are treating. Now, this data that I have on board is actually from the Illinois Corrections Office. They also employ telemedicine. This is relatively recent. This is in 2014. UTMB, with its contract with the Correctional Managed Care System, has been employing telemedicine for the last going on 20 years now. Now, our EHR necessarily is also about 20 years old. The problem why it's not so prevalent in all of the other prison systems is that the big setback is the EHR and the cost of the technology. It's not cheap to put a camera in each of those 113 places. So, but we managed it, and our EHR is a cobbled together Word documents that through the years have evolved. Now, the setback as far as making this nationwide is that our EHRs all speak a different language. So that one system may be using Epic, which is what you all are familiar with if you're working with UTMB. You will have another system that's using Amazing Charts, and you will have another system that's using, I believe it's called Athena. So these are big vendors for EHR. And since the Affordable Care Act mandated that in 2016 we will all be using EHR, sounds like this is the advent of telemedicine, both in the prison and in the free world. But not quite yet, because we're still talking different languages. The other thing, like I said, the cost of the technology. Now, that's also coming down, with the Skype and video conferencing that was made possible by the newer technologies. That's also becoming a little bit cheaper. But there's still the issue of privacy and encryption. So it is not as simple as just dialing Skype and talking to the prisoner. You have to have encrypted technology so that people will not be able to hack into your system and find out the medical issues that you're dealing with. So there's still some setbacks. But looking at this table, you can see the big difference as far as before telemedicine and with telemedicine. Because now the prisoners that are included in this study have access to the specialty care that before they did not have. They are relying completely on the know-how of the unit provider. Which moves us to the next challenge. Now, the unit provider's knowledge of how to take care of patients living with HIV are variable. So some of them have a lot more know-how, and the transition of the patients taking care of people that are incarcerated has also got a high recidivism. Because if you think about it, you're choosing to go into corrections healthcare. You're choosing to deal with these people that have very likely a violent past. They are in prison for something. And some of it could be rape, some of it could be murder, some could be aggravated assault. And you are choosing to mingle with these people. So, some have a higher tolerance of the feeling of safety being inside the prison system. Because when you walk in there, it feels like you just got imprisoned yourself. The only difference is you get to go home at the end of the day. But when you enter a prison system, you are patted down, you go through a metal detector, you're not allowed to carry your cell phones, you're not allowed to carry your purses, or if you do, you're going to be checked. And if you are going to bring lunch in there, you're going to have to comply with the regulations of the prison system. So a lot of times you end up eating the same prison food that's being served to the prisoners. So basically, you're choosing to be incarcerated yourself. Okay? And most of these prisons are located in out-of-the-way areas. So when you're driving to work, you're really going into the middle of nowhere. And it's designed to be that way because prisons are not supposed to be in populated area. If you're going there and your shift is like 6 in the morning, you will be driving in the middle of darkness at 5 in the morning. And if your shift ends at around 8 in the evening, you would be living in the middle of darkness too. And these areas usually don't have good window systems. So it takes a special person to take care of patients that are incarcerated. As I mentioned, corrections medicine is very different than pre-world primary care. If you think about it, well, you know, they're the same patients. They have the same problems. But most of these people that are in prison are actually the marginalized population. That's actually how they ended up in prison to begin with. So if they are in prison for drug use, most of the time they are not going into regular doctor's visit. It might be the first time that they're actually encountering health care when they enter the prison system. So the providers in the prison system would be dealing with the total state of health. So when you're in the intake, you look at this patient and you don't just think HIV. You think, okay, the diabetes is probably out of control. They might have lice. They might have, you know, they're carrying a whole lot of rashes. They have bed bugs with them. They have all sorts of problems that they're going to go in with. And the last thing that the primary care provider in prison going to think of, what is HIV? Or at least HIV will just be one of the problems that they're going to have to deal with. The most immediate thing that they need to deal with is to get this patient's blood pressure under control, blood sugar under control. So survival mode is the first view rather than taking care of their HIV problems. Now, if you're an HIV provider in the free world, the first thing that you're going to look at is this patient's HIV status. So that you know that they are HIV positive, you're going to look at their medication, you're going to look at their CD4 count. That's your first priority. And then all the other problems that goes behind it, then you do your primary care. So you look at their sugar, but your focus is completely different than a unit provider that's practicing in prison. And HIV care these days, 25 years since the beginning of this epidemic, is being taught in all of the medical, nursing school, PA school that you go through. Corrections medicine is not. It is something that you go in and you get baptism by fire. You pretty much learn as you go. Now, as I mentioned, the knowledge of the unit provider is variable because HIV care has evolved. Our knowledge of HIV care has also evolved quite a bit. Since I put here the timeline just to demonstrate that, you know, in 1981 we didn't even have a name for this. At one point it was called GRID, or gay-related immune disease, before we came up with AIDS. And we've come a long, long way from trying to figure out what's going on to our providers these days who haven't seen probably but a handful of cases of immune opportunistic infection. For us long-timers who have practiced in the age of when the epidemic was in bloom, we have our first encounter is actually the opportunistic infection that these patients would walk in with. But with the advent of our active antiretrovirals, it's become the challenge now is how to simplify their regimens. You know, we've gone to taking 60 pills a day to 1 pill a day. And even at this point, we're actually looking into prevention or having patients who don't have HIV start taking medicine so they will not contract the disease. So that is a big difference than what we had started out with. So if you are a practitioner in corrections, you have seen the whole gamut, and it's hard to keep up because it's not only the changes in HIV care that you need to keep up with, but the changes in primary care too. So you have to keep up with what are the new medicines for diabetes, for high blood pressure, for all of the other ailments that they come up with. Okay. Even the testing that we employ is different. You know, for a long, long time, almost a good 20 years, we were doing the ELISA test and then the Western blot. So we've gotten so good at it. But we have taken it one step further, and we now have what we call a fourth-generation testing. So this can be challenging if you're a unit provider and catching up not just with the medication, but also the interpretation of the tests and what does it mean. Okay. The third challenge, the preventive measures that we take for granted outside the prison system are actually not compatible, or at least not implemented in the prison system. Because the stance of most prisons, not just in Texas, but in actually all over the world, is that sex does not happen in prison. And so distributing condoms is actually promoting sex in prison. Now there's a study in Queensland, in Australia, that actually, and it is in the references at the end of these slides, that actually looked at, they have progressive thinkers, so they distributed condoms in their prison. They experimented with 2 units in the prison in Queensland. And they found out that when you distribute condoms or make it freely available, it did not increase the incidence of sex in prison, but it increased the practice of safe sex in prison. So it takes changing attitudes of people who actually do not deal with the HIV epidemic day in, day out to try and get these policies on board. Because it's not even 10 years ago where the stance of the far right actually is that abstinence is the rule. So even in the free world, they will not allow condoms, and they had these teenagers signing a contract of abstinence. I think that's got fallen the wayside now, and they pretty much found out that that kind of thinking doesn't work. Unfortunately, these days that HIV is no longer front and center of the media news. The rising incidence of HIV is in our youth, in the marginalized youth in the big cities, because of increasing use of drugs. Now, which segues us into needle exchange, because we come to the second truth inside prison, that drug use does not happen inside the prison. And so, as making needles available for needle exchange is actually also not a good practice inside a prison system. The other thing is that we need to also look into the issue of safety, because these are violent people, so they have found ways to use needles as a weapon, and so the needle exchange is a little bit controversial. This is a picture out of China when they were promoting condoms use for HIV awareness. Thought it was cute. Anyway, so challenge number 4 is lack of resources for testing. Now, in Texas, we are one of the more progressive prison systems where we actually offer HIV testing to all of the incoming prisoners. And we have what we call an opt-out policy, meaning The testing is voluntary. We offer it to everybody, and the prisoner has a right to say no. Now, there was a study about 4 or 5 years ago that actually looked at the opt-out option as far as how informed consent is it really when you are being asked to take an HIV test. Now, majority of patients in the jail and prison system actually agree to get themselves tested, a good 82% of them. But a pretty good number, I think, if I remember right, about 52% actually thought that it's not a voluntary testing. I actually did not quite understand the informed consent nature of the opt-out testing. Because these people are being accustomed to live in a regimented environment. So that something that may sound optional to us may not quite sound the same to them, that this becomes a requirement. One thing that is a requirement is the pre-release HIV testing, because we want to make sure that they are not picking up HIV once they go through our prison system. So that one is not an opt-out. That's actually a universal testing, mandated testing. Now, there are a lot of prison system in other parts of our country or actually even in the world that they don't have the resources to offer the testing because it costs money. And then the other thing is, what are you going to do after you get these people tested? So, actually it's a Texas lawsuit that prompted healthcare in the prison system. It is now, prisoners are the only group of people in our country that has a right to healthcare. It is actually a requirement that they be provided standard of care because we have taken away their choices when we put them in prison. Now, the study that looked at the opt-out testing also look at the time frame in which the testing needed to be done. Especially vulnerable are the jail population because they're very short transit. They can range anywhere between 2 days to 2 years because they're still waiting their sentence or whether they're going to be convicted. So, the testing needed to happen within the first 24 hours that they go in. Because by 7 days, there is a big attrition as far as getting the HIV testing done. So that they agree more, or there's a higher rate of pickup of patients that have HIV when they get tested within the first 24 hours of incarceration. Okay. Challenge number 5, and I actually got called onto this. The privacy concern during visits. If you are in the prison system, generally there is a chaperone, or there's 2 of you in the room, and that's about the same as when you are getting checked in the free world. When you are in telemedicine, there is a presenter, so that you can think of that's the nurse that goes in the room with the patient. But if you have a segregated patient or a patient that's considered more violent than others, for one reason or another, they are segregated from general population. Usually there will be a guard that's going to be in the room with the patient. And even though I got called into this, that they have changed the policy, and only when the presenter feels threatened do they require having a guard in the room. But with prison violence as it is, most of the time there is a guard in the room present while you're having a discussion about very intimate details of their health care. And even though in the free world we are a little bit more accepting that, HIV is just another disease, in prison there's still a stigma as far as being labeled HIV positive. And at some point, I actually got asked about an HIV patient biting a security officer. And he is actually being charged with an assault with a deadly weapon, because potentially he can transmit his HIV to the officer. So it's a totally different world and a totally different population, even though they are inflicted with the same disease. But in all the other, in the rest of the world, privacy is still a big concern, and the stigma of HIV is still something that prevents patients from seeking help just because they can get targeted in prison. Okay. Big thing, taking medications and the compliance issue. Now, we literally have a captive audience when we are treating HIV patients in prison. They really don't, they have a choice or they have a right to refuse treatment, but their treatment is regimented. They have to come to the pill window to get their medicine. So, if you think that it's hard to take medicine twice a day when it's sitting in your medicine cabinet, these people's lives centers around the pill window, because they're told when to wake up, when they can eat breakfast, and then you line up, and it could be anywhere between 50 people to 100 people long in the morning, and it's not air-conditioned places that you line up with. Sometimes you could be lining up in the middle of the heat or in the middle of the rain, because depending on the structure of the prison system, the pill line, since it's running so long, would probably be a little bit of it will be on the outside. So these people has to weather sun and rain in order to get their medicine. After 2 hours of lining up, they go to lunch, and then they go back to the line to get their evening dose. And so, I mean, they have to be really motivated, and it's up to us to motivate them and convince them that this is for their own good. But think of it, if that's your entire life, and you're going to do that, if you have a life sentence, you're going to do that the rest of your life. So we try to simplify their regimens. The pill window only opens twice a day. So all of the medicines that we pick generally are twice a day pills. If we can get away with once a day, we try to do that, to try and make it a little easier for the patient. But there's also trying to empathize with patient. I'm sorry, I'm jumping back to the challenge number 2. But trying to empathize with patient, just as we are trained to do during our training, is actually frowned upon when you are inside the prison, because that can be looked at as fraternizing with the prisoners. And so a lot of the people who work in prison actually don't necessarily call them patients. So I usually get told that this is offender so-and-so or inmate so-and-so, because you want to put a little bit of a distance from yourself, because you can be, you can be subject to disciplinary action if you are found too friendly with the prisoners. So trying to empathize with them or working with them to try to increase their compliance. It's a thin line that you walk, because sometimes you will order things to make life a little easier for them, and it might not be compatible with the security needs of the unit. So, and the big difference with HIV treatment is that once you get started on the pills, you are on those medicine for the rest of your life. So it's a big commitment to say, okay, I'm going to start taking my medicine, And just like the rest of the world, we start getting lazy somewhere down 2 or 3 years down the line, and we start forgetting our doses. I actually got asked, maybe we will increase compliance if we make HIV medicine KOP. This is another terminology that if you are not working in prison, you will not understand. But KOP means keep on person. It is something that they can take to their cell, and they will have the autonomy to take their pills at the time that they want to take it. The problem is, just like all of us, we start forgetting taking our doses. And when they have a stash of medicine in their cell, they can get a case. These medicines are very, very expensive, so we want to make sure that when we provide this to these patients, that it's being taken properly. And it's easy for us to say, well, I got extra pills because I forgot to take my doses before, and you are responsible for your own health. But when you are in prison, you're not only responsible for your own health, you're responsible for the health of the other people around you. Case in point, we recently had HIV and hepatitis B co-infected patient. And he decided he doesn't want to take his medicines anymore. Now, it's his life, and he doesn't want to take his medicine. His health care is going to deteriorate. The problem is, he is a big risk to everyone around him because his hepatitis B is also now multiplying because he stopped taking his medicine. And so in cases like this, we actually, short of forcing them, we try getting them to come in and have a direct observed therapy, because they are putting the healthcare workers at risk with their hepatitis B. So this is still a big challenge as far as getting the compliance, because even if you make these medicines KOP, you are not assured that they will actually take their medicine. We actually, when my nurse was still in one of the units, Sustiba, or efavirenz, because of its neurologic side effect, where people start getting a little high with it, actually became a black market in the prison system. So they started selling Sustiba to some of the patients who want to, or one of the prisoners that want to feel high with the Sustiba. So it's the prison environment is very different. Okay. So sometimes doing this doesn't exactly work. Now, exposure to other infectious disease in a close quarter environment. That's something that we really cannot do a whole lot about. And this is an example. Because of the limited space that we have to work with, the prison system is generally in a dorm-like setting. And so they're breathing the same air. When you close all of that window and you do not know what these people are carrying with them, they are in close contact with each other. So MRSA becomes a problem. Tuberculosis becomes a problem. During the flu season, we try to vaccinate everybody because the moment that you get flu in there, it becomes a big problem. And this is true not just for our prison system. This is actually not Texas. This is Alabama. But in all the prison system of the world, because you're trying to put together a bunch of people in a very small space. Now, the last challenge we're going to tackle is the post-release treatment and linkage to care, because we do not exist in a vacuum. So we treat these people, as you can see in the table I've shown earlier, where they improve the HIV care of these patients. They're getting their medication, they got their viral load down, and then they get released outside. And once they do, they lose that pill window. There's no longer a regular supply of their medicine. They are now they can no longer just put in a sick call to the nurse and they'll see a doctor. The access to care is lost. You got to go through what the rest of us has to do. You have to find yourself a doctor. You have to call and make an appointment. And you actually need to pay money sometimes to actually get to your doctor's appointment. It is a big challenge once these patients get released. This is the statistics. A study, actually, this was done in Texas between 2004 to 2007. Only 5% took their prescription and get it filled. See, when they walk out of the Texas prison, they walk away with 10 days worth of medicine. Meaning you got 10 days to get yourself to a doctor, get a prescription, and get your medicine to continue. When you walk out of the prison system, thinking of your doctor's appointment, I think, is very low on that list. The first thing that you think of is, who's going to take me home? And where is home? And how am I going to eat? Who's going to feed me? Because in 10 days, I don't think they're going to trip over a job that's going to pay them money to be able to live. So, thinking of getting their medicine is very low in that totem pole of priorities. So only 5%, and within 30 days, somewhere down the line, they missed some doses, but they figured, hey, I got a prescription, I can go to the drugstore. So 17% will fill their prescription within 30 days after they've gone through the first priorities. And only up to 35% access care, meaning there are free clinics that they can go to. And only about 20 to 35 actually go there. Now, so discharge planning, or once they get released, or release planning, is very important. Because based on this study, they actually found out that if the prisoners or HIV patients that are going to be released has received health education and has gotten all of the other intricacies of getting into the system in the free world taken care of, their access to care goes up within the first 30 days. We have a program in Texas where we actually have discharge planners that talk to these patients 3 months before they are released, and hopefully within a few weeks before their actual release. We also have segment of the TDCJ that arranges for their appointments, provides them, I believe, with some coupons or vouchers so that they will have food stamps. So that and the linkage to care has gone up to 50% from our last survey. Because this is a program sponsored by the DHHS. So they are actually following these prisoners once they get released and looking at what their linkage to care behavior. So, in the prison system in the States, there is a study that was done. It's a little bit old. This was done, I believe, in 2007, where they surveyed all of the medical directors in the 50-state prison system. They had 46, I believe, that responded. And in that response, they have a questionnaire. They outlined what is their discharge planning. So the study authors actually defined what they consider as the minimal or the least amount of discharge planning that are being done for these patients. And they are given a supply of pills and a list of local HIV providers, and then you're on your own. That's majority. That's 24 out of the 50 system that we got. Now, slightly better, they actually make an appointment and they're given a copy of their medical record along with their supply of medicine. And about 12 prison system does that. And the best, unfortunately, it's only 8 systems that actually do the best, which is what the CDC has recommended. They are given a supply 10 days of medicine. They are given a prescription that they can take to any of the contracted pharmacy. Walgreens, I believe, is one of the contracts. And it will get them 30-day supply of medicine with 1 refill. So that's essentially 70 days worth of medicine. They are given an appointment with a community provider, a copy of their medical records, and they are helped to enroll in the Medicaid program or the Ryan White program. So that's the best care. And I'm proud to say that Texas is one of the 8. But when you make that much effort in their pre-release planning, these patients actually link to care so we don't lose them, and they actually get better practice behavior in order to prevent spreading their HIV. Okay, this is the references. That's all I got. If I have missed some of the challenges, I'm sure that my colleagues in the prison system is going to call me on it. And I'd be happy to answer your questions. Any curiosities? Yes, sir.
Is the system in the private system similar to the health system in the big one?
Not necessarily so. In the private-run prison, it's very variable as far as the kind of care that they get. I mean, they have the same mandate that we have, but they don't necessarily provide specialty care, especially for HIV. At the most, they will probably continue what they have been having from the outside. So it varies. Some of the private prison actually contract with facilities, big facilities like UTMB or Texas Tech, and to be able to provide their HIV care for their patients. Anything else? I don't have any jokes for you. I think Dr. Kaiser already took care of that. If that's all, I thank you very much for your attention.